we'll get started. Thank you everyone for joining us this afternoon for our second part of our three-part series from emergency to everyday. We are so excited to have such a large, great group here to join us for a wonderful discussion that we have planned for you. I'll introduce our panel in just a moment, but we're so excited to have Dr. Deborah Friedenberg and Carol Johnson here today to share a bit more about their experiences and personal reflection over the last year of COVID and being involved in a state newborn screening program. This series has been a great opportunity for us to come together as a newborn screening community and reflect on the lessons learned from the different perspectives within the newborn screening community. And we're really excited today to spend some time specifically thinking through the state newborn screening program experiences. Thank you for joining us. We look forward to a great presentation or set of presentations, as well as some great discussion towards the end. My pictures, pardon me. We would like to disclose, that the work of the Newborn Screening Family Education Program is funded and supported by the Health Resources and Service Administration. And specifically, this webinar series has been funded through supplemental funding that we received from HRSA through the CARES Act this year. We did also want to just address a few quick tips and items for the 60 minutes that we're together. We did want to let you all know that we do have live captioning available for anyone that is interested in utilizing this. You can access live captioning by clicking on the More button in the navigation bar at the bottom of your screen, and you can select to turn on or off live captioning and transcription. So for those that might want to utilize that, we encourage you to do so. And if for any reason you have any technical issues at all accessing live captioning or throughout this webinar, please don't hesitate to message us in the chat box. We do have different team members from Expecting Health available to address any technical concerns that might come up. We know that technical issues happen, so please don't hesitate to reach out. And we do also encourage you all to engage in discussion in the chat box as well throughout this presentation. We look forward to some great comments and discussions as we go. So before we jump in, we do want to just quickly address and find out who we might have joining us today. So we would love for all of you to participate in a brief poll so that we can learn a little bit more about who is joining us today. So on your screen, you should be able to see a poll. There are multiple questions, so we would love for you to take a few minutes to respond to these questions. And don't forget to scroll all the way down before submitting. We'd love to find out which stakeholder group you might be representing in attendance today. I know we have some family members that have registered to join. We have a number of representatives from the various different state programs. We may have some industry representatives. It looks like we have some researchers joining us as well. It's great to see such a broad and diverse group of individuals here today. We'd also like to understand and learn a little bit more about what you're hoping to achieve during this webinar. Are you looking to listen and learn? Are you hoping to have some of your questions addressed? Are you looking to brainstorm solutions? So we'd love your input there as well. We'll give it just a little bit longer, and then we'll share the results of this poll with you all. For those that are just joining us, we're starting off with a quick poll to understand a little bit more about who's joining us today and what you're hoping to achieve during this webinar. Fantastic, great. Thanks so much for joining us and for sharing that information with us. It looks like we have quite a few different representatives from state newborn screening programs, which is wonderful to have you here and be a part of this discussion. We also have a number of researchers and healthcare providers. We have some family representatives as well. And it looks like we are all here to brainstorm as well as listen and learn. So I think we'll definitely accomplish that. So thank you again for sharing that with us. Okay, So I wanted to just briefly share what our objectives are for the next 60 minutes or so. First and foremost, we want to understand the key stakeholders of the newborn screening community, knowing that we have such a diverse audience and knowing that many of you are already extremely familiar with the newborn screening system. Many of you already have this understanding and knowledge, but we just want to lay some groundwork and a foundation so that we're all coming from the same page on that. We want to learn, again, specifically from the state newborn screening perspective. How have state newborn screening programs supported families through not just COVID, but also concurrent public health emergencies? And I think we have a really unique opportunity today to learn from two state programs who have had to juggle quite a bit over the last year on top of navigating and managing COVID. And then lastly, and probably most importantly, we really want to take those lessons learned from these experiences and think about how we can apply those lessons to support families through future health emergencies. And really, that is the goal of the work of the Newborn Screening Family Education Program, is how can we continue to support families throughout the entire process of newborn screening. So again, we are extremely fortunate to have a great panel today with Dr. Deborah Friedenberg and Carol Johnson, who are each going to be sharing their perspectives about their experience over the last year. I just want to briefly introduce both of our panelists, and then they'll have an opportunity to provide some additional information and introduction when each of them speak. So Dr. Deborah Friedenberg is board certified, in pediatrics, medical biochemical genetics, clinical molecular genetics, and clinical genetics and genomics. So a number of different board certifications. She received her medical degree from the University of Buffalo School of Medicine and Biomedical Sciences, and her graduate degree from Mount Sinai School of Medicine. She has a tremendous amount of experience in clinical, academic, and public health settings. And since 2009, she serves as the medical director for the Texas Department of State Health Services in the Newborn Screening Unit and Genetics. So we're eager to hear from you today, Dr. Friedenberg, and thank you for joining us. We also have Carol Johnson joining us. Carol is the follow-up coordinator for the Iowa Newborn Screening Program and has been in that role since 2011. She's also the co-chair of the Association of Public Health Laboratories Short-Term Follow-Up Work Group, as well as the co-chair of the Association of Public Health Laboratories Workforce Task Force. Carol also has the pleasure of working directly with Alaska, North Dakota, and South Dakota newborn screening programs through their Quad State Collaborative. So clearly we have a wealth of experience and knowledge. Many of you joining us are already connected to and partner with both Dr. Friedenberg and Carol, so I know you're probably eager to hear from them as well. So thank you to both of you for being here today and for sharing your experiences with us. Before we jump into our panelists' presentations, I did want to share just a bit of information regarding the questions that were asked during the registration process. So you may recall that we did inquire about your specific experiences and how you felt those related to the COVID-19 pandemic. And thank you for those of you that were able to respond to that. Interestingly, and not surprisingly, we saw quite a varied response. So we had about 15 individuals who responded saying that COVID-19 really may not have impacted how state newborn screening programs support families. We had roughly 41 out of about 94 respondents, so almost half that responded that COVID-19 may have had some negative impacts on the way state newborn screening programs are able to support families through this time. And then we had a number of individuals who thought it was a positive impact. And so I think that's a really interesting, and hopefully we'll hear a little bit about that today from our speakers. And then certainly a number of individuals who are still just maybe not quite sure and still figuring out the impacts of COVID-19, which is also not surprising. I know this is a bit of a busy slide, but I think it really illustrates that we got quite a variety of responses to the question of what resources would help state newborn screening programs better support families, especially during emergencies like COVID. So some of the highlights or some of the messages and suggestions that we heard were things like adequate staffing, Forums such as this discuss what the specific challenges and successes of navigating a pandemic like COVID-19 have been. We certainly saw a lot of suggestion for increased funding to support things like patient and provider education, to support food aids and the psychological and psychosocial support services that families might need, navigating not just newborn screening, but during a pandemic and additional health crises as well. Um, Additional suggestions like accessible information on where to go to be able to complete confirmatory and follow-up testing, more outreach to parents, again, funding, and resources to prevent or reduce burnout. So I think it's a really helpful list to have as context before we go into these discussions and thinking about how can we continue to improve experiences. What are the things that we need as a newborn screening community to really think about family-centered experiences and ensuring that family needs are met throughout this process. So for those of you that attended our first session of this 3-part series, this may look familiar to you. And for those that maybe are joining for the first time, this may be new, but wanted to just lay out that really the framework for this discussion is to think about different perspectives from within the newborn screening community and sharing those perspectives specifically with the framework of what did you think about starting at the onset of the COVID-19 pandemic. What, as that individual stakeholder group, did you stop doing or did you have to stop doing as a result of the pandemic? And what are those key lessons learned and specific strategies that may have been implemented that we want to think about continuing as a way to support families and continue to grow and expand on? So as you listen in to the presentations from Carol and Dr. Friedenberg, we can keep that framework in mind, and we'll revisit that again at the end of this session, but really thinking about what as a community and specifically as state laboratories can we start doing for future health emergencies? What can we think about stopping in that time, or what do we have to stop in that time, and what can we continue and build from? So with that, Carol, I am going to turn it over to you.
All right. Good afternoon, everybody. Thank you for inviting me to present today. And as Mariana said, we're going to hold questions to the end, but I certainly look forward to those. So I'm going to talk today about newborn screening during a pandemic and a natural disaster. And Dr. Friedenberg is also going to talk about this from the Texas experience as well. So next slide, please. So the pandemic was a new thing to all of us, right? There was lots of scrambling that everybody had to do. However, in Iowa, we were fortunate that we had some of our nuts and bolts already in place. So we were a program that was already used to working 365 days a year. We had a courier and our newborn screening program that had some good relationships developed with our birthing facilities and some of our PCPs. And that proved to be very valuable as the pandemic continued. In our laboratory, you know, everybody was concerned about how are we going to socially distance in the laboratory? How's this going to work? And we already had a day shift and a night shift in place, and they've been in place for several years. And so we automatically had some separation of staff so that, you know, heaven forbid somebody got COVID or somebody was exposed to COVID, it didn't take down the whole laboratory. What follow-up did is we were allowed to work from home. So that allowed for, again, appropriate social distancing, et cetera. We also were used to working from home for weekend and holiday call. And we also utilize a web-based case management system. So we can, as long as there's power and internet, follow-up can work from anywhere. Next slide, please. That said, we did make some changes in the very beginning. So the laboratory identified that they really wanted to be able to send their data entry staff home to be able to work from home. But in order to do that, they had to develop a new workflow for that data entry staff. And they also identified, remember back in the beginning, we were really concerned about COVID being, or the coronavirus being on surfaces. And so, between that concern, as well as, again, trying to get that data entry staff working from home, they worked towards a more paperless approach or a process to reduce multiple touches for a document. And then eventually, and I'll speak more about this in a second, follow up was working on these little laptops exclusively, but then eventually we were able to purchase docking stations and another monitor, which made working from home much more palatable. Next slide, please. So I wanted to talk about some realities. So the reality is that babies born during the pandemic still had newborn screening disorders. So that means newborn screening had to go on, right? We didn't get to, as Mariana said, we didn't get to push stop. We had to keep on going and continuing. So some of the issues that we saw right away is some of the laboratories closed locally. So there was access issues to get confirmatory testing done or even repeat screens done. We saw that if laboratories were open, you had to schedule an appointment and they only had one patient in the room or in the laboratory at a time. And so that made things more complicated for the family. We also had to figure out how to handle some very legitimate concerns from parents about taking their baby and themselves and family members out to get confirmatory testing done or a repeat screen done because they would, in theory, be risking exposure. We also saw that our home births increased in our state. And we also saw that midwives told us, I am doing more deliveries than I ever have. We also had one midwife say to us, my clients that I have delivered were never really interested in newborn screening before, and now they are, and I'm not sure how to navigate the system. So that was interesting. We also had some parents who wanted to leave the hospital as quickly as they could. Again, they wanted to decrease their exposure to COVID. And so they were leaving the hospital before that 24-hour period when we would normally collect the newborn screen and when we would consider that screen to be a quality screen. Anything that's collected before 24 hours and 1 minute, at least in Iowa, is considered an early collection, and we need to get a repeat screen. So while these families were thinking they're reducing their exposure, and they may indeed have, they also had to risk another exposure because we still needed them to take the baby to get a repeat screen. Next slide, please. We also noted that refusals increased. However, we'd been seeing a trend toward this for the last few years. And so we're not sure yet if that was because of the pandemic or just a natural increase in refusals. And then I'm going to kind of lump several things all together here is that the other reality is that hospital staff and clinic staff also got COVID. So there were staffing issues. Um, People were being redeployed to do jobs that they had never done before. We saw that a lot of people collecting newborn screens really hadn't done it before, and that was really affecting our quality of our samples. And so, right when you want all the samples to be great and not poor quality in the middle of a pandemic so that parents didn't have to bring their babies out, we saw an increase in poor quality samples, unfortunately. Next slide, please. We also had a few hiccups in our system. So the courier that works for us in newborn screening is also the courier for the Iowa Department of Public Health. And so overnight, this courier went from picking up newborn screening samples and a few other samples to picking up about 1,000 COVID samples a day. So this was very stressful for our courier. They had to hire some additional drivers. So life was pretty tough for our courier. And then again, overnight, places where they were always allowed entry into, they couldn't get in the door anymore to pick up samples, or they had changed the place where they were supposed to go pick up the samples. So this made us be very adaptable on a very in a very quick basis. And we found out that communication was absolutely crucial during those first days. And again, some hiccups. Again, I said that we didn't have all the equipment we needed right away for follow-up. And we continued to have connectivity issues because we were working on a remote access platform versus a VPN. And believe it or not, we just got VPN access about 10 days ago. So yeah, we've been doing a lot of workarounds. And supply chain issues were a constant during the pandemic, and they still continue to be a problem today. Next slide, please. So I also wanted to drill down on a specific disorder just to share a story with you. So we have two accredited CF centers in Iowa, one in Des Moines, which is in the central part of our state, and one in Iowa City, where the University of Iowa is, which is in the eastern part of the state. The CF Center in Des Moines decided to close its doors. So right away, we had an access issue, right? And then, as Murphy's Law would go, we had brand new consultants for our CF newborn screening uh, team. So they were, really only about 3 weeks into working for newborn screening, as well as doing their, as we joke, their day job. So they really didn't have, they had some basics of newborn screening, but not all of them. And here we were asking them, we've got all these problems. What do you want us to do? We need to change the protocols. And they're brand new to the process. Now, they rose to the occasion and things worked out great, but it was a tense time, not going to lie. So we also, besides the access issues, we ask ourselves the question, in CF, what results absolutely need a sweat test and which ones can we delay? Now, remember, in the beginning of the pandemic, we had no idea we would still be doing this today, right? We were thinking weeks. And so the answer at that day is a very different answer today. And then how can we make that as safe as possible for those families who have to come in? So ultimately, after discussing these cases with the families, they all opted to make the drive to Iowa City, which in some cases went from 1 hour to 3 hours or even longer. And they did opt to do the sweat test. So we were very pleased with how that worked out. But getting from A to Z, again, was kind of a tense situation for a while. Next slide, please. And then in the middle of a pandemic, on August 10th of 2020, we had a derecho. So what the heck is a derecho, right? I had never heard that word until it happened to us. So essentially a derecho is a hurricane inland, not on the coast. So much like hurricanes, we had winds that went up to 140 miles per hour. The derecho affected several Midwestern states, and the hardest hit area was in Iowa, particularly in the Cedar Rapids area, which is eastern Iowa and is only about 25 miles north of Iowa City. And that means 25 miles north of follow up and all of our medical consultants for the program. Next slide, please. So here are some images. The one on the left certainly looks like a hurricane, pictures of hurricanes I've seen. And then the one on the right just shows you um, a glimpse of some of the damage. But Cedar Rapids lost 75% of their tree canopy in the derecho. So it's going to take years to recover from some of that. And next slide, please. So the aftermath of the derecho was that many clinics, businesses, and homes were without power for days or even weeks, even up to 10 weeks in some areas of Cedar Rapids. Some cell phone service was knocked out, and the derecho affected families and healthcare providers across our state, as well as directly some of our newborn screening staff. So they were without the basics, and they didn't have power, might not have cell phone service, significant property loss or damage. And in some cases, those places without power or the internet, people had to go find a new place to work. Next slide, please. And then, as if those two things weren't enough, in Iowa, we had a very significant second wave of COVID in the fall of 2020. And why this was different with PCP offices from the beginning, we're not sure. But during the fall of 2020, we had a significant issue trying to reach PCPs because of all of the high volume of phone calls that PCP offices were having come in. Our staff waited for 20 plus minutes, sometimes up to 40 minutes, even when we were trying to report a time critical result. And as you all know, that minutes, hours, and days really can make a difference in an outcome for a baby. So this was a stressful situation for our follow-up staff. In some of our larger clinics in Iowa, they have a separate physician line versus the line that patients call in on, and we utilized that whenever possible. But still, we were on hold, sometimes for 10 minutes or more on the physician line. Next slide, please. So that's the story. And now what have we learned? And what reflections do we have? So the in this, I'm going to use the word reality again. The reality is that our PCPs and clinics still primarily use phone and faxes to communicate and do their job. That wasn't working very well during the derecho and during the fall with the pandemic. So, how can we get PCP offices to embrace email, texting, and other tools uh, to improve communication or to provide us alternate communication during a disaster? And then, how can we incorporate parents into the communication stream, particularly during a disaster? Like, if you're on hold for 40 minutes with with that baby's PCP's office, should we just call the parents directly? That's typically not what we do in Iowa, but maybe that's one of our new plans, right? And is there a way just to make we ask this question all the time, is there a way to make the newborn screening process better for families just in general? And the other lesson that we learned is we actually did prove that technology can be leveraged to improve communication and the newborn screening process. We also proved that we can work from home and follow up and do that successfully, and that hopefully we will be allowed to do this during snow and ice storms that we typically have in Iowa in the winter. And, unfortunately, we had a newborn screening program in this country that had to evacuate their building due to a riot. I mean, it isn't just the tornadoes and hurricanes anymore that newborn screening programs used to be prepared for. We have a plethora of things that we need to be prepared for. Next slide, please. And ultimately, and this was not without pain and blood, sweat, and tears, as they say. But in our blood spot program, we do not think that the pandemic caused major problems to any of the babies or the families that we serve. And the same can be said for the derecho as well. We know that babies did receive their specialty services that they needed, that testing did get completed, and we were ultimately able to determine if a baby had a disorder or not. So ultimately, at the end of the day, it all worked out. Next slide, please. And I would like to thank you, and we're going to hold questions to the end. And I actually forgot to put my contact information on this slide, but For the staff of Expecting Health, I give you permission to give out my email and my phone number if somebody asks. I'm happy to continue this discussion offline with anyone who would like to. So thank you.
Fantastic, Carol. Thank you so much. And we'd be happy to put your email in the chat box as an easy way to share that with everybody that's attending, so we can make sure that anyone interested can follow up with you directly. Thank you so much for that. I am sure there are many questions. I know it's gotten me thinking as well. So we will hold those until the end. We'll have plenty of time for discussion and questions. But as we move through, it's perfect timing, I think, to engage you all as listeners based on some of the things that Carol just shared, in particular, knowing that outreach to families directly is such a critical and integral part of newborn screening programs. We wanted to find out from you all what you think parents and families find most comfortable as a way of receiving information from newborn screening programs. So we have another poll for you. I would like to take a few minutes to get some feedback from you all. So again, we're looking to understand, and we realize that some of you may be answering as families who have experienced that outreach as a family member, and others may be working for state programs or part of outreach and follow-up that are contacting families. So depending on your perspective, we'd really like to think about and understand how you think parents or families are most comfortable receiving information from the newborn screening state programs. Is that a phone call? Is that a text message? Is it through a telehealth visit, through a visit, through video chat? And we'll just pause for a few minutes to let everyone respond to this, and we'll again share the results shortly. Great. Thank you all for your responses and perspective. It looks like kind of a close tie between phone call and or text message from, it looks like, a healthcare provider as well as a healthcare visit. So I think that's, just really interesting to think about as we again expand on and grow from the lessons learned through this pandemic and the adjustments and innovations that had to be made quickly when centers were closed and outreach was more challenged. I think taking some of those strategies and thinking about the future is really helpful to think about. So with that, I am going to transition over to Dr. Friedenberg, who is going to share a bit about the Texas experience. So Dr. Friedenberg. Oh, you may be muted, Dr. Friedenberg.
Yes, now I'm muted. Thank you very much for inviting me to share with you some information about the Texas Newborn Screening Program. And just to start, we shared many of the same challenges as the Iowa program did. And so I want to thank Carol for laying them out so clearly and helping to think through some of the issues that they faced as well as we faced. Next slide. So this is reflections on a year of COVID-19 and newborn screening, and there was lots going on in this year. Next slide. Newborn screening is a system. It is not just the state newborn screening program. It is not just the laboratory and follow-up. It involves families, babies, couriers, as you've heard about, insurance policymakers. It is all interconnected, and in order for a baby to receive the benefits of newborn screening, all parts of the system need to be collaborative and need to be working well. Because essentially, if a newborn screening program does everything perfectly and identifies a baby at risk, notifies the healthcare provider responsible for that baby, but for some reason that baby doesn't get those services, it doesn't really matter what we did. The end result is that the baby needs to get the appropriate care and evaluation. And so there are lots of moving parts to this. And although this is a static slide, I have this vision of it circling around in 360 degrees because it is a moving target as well. Next slide, please. Okay, I wanted to share with you just a little bit about the Texas Newborn Screening Program, and just to give you an idea of how we function and what changes we made and what challenges we face. So in Texas, we have one central laboratory in Austin, and all of the newborn screening blood spots are analyzed in that one laboratory for the whole state. And our clinical care coordination, which links the babies to clinical care, is also located on the same campus. Currently, we screen for 54 disorders on the blood spot and 2 point-of-care screenings, including hearing loss and CCHD. And in addition, we are a 2-screen state, which means that we recommend every baby gets screened 24 to 48 hours, and again at 7 to 14 days of age. And that 17 to 14 days of age became the challenge in the pandemic, getting that second sample. Next slide, please. So we are the largest newborn screening laboratory in the United States. There are about 370,000 births per year, and that's down a little bit from previous years. And we handle nearly 713,000 specimens per year. For 2020, we had about 4,500 unsatisfactory specimens, which was about 0.63% of our total specimens. The lab operates and follow-up as well, operates 6 days a week, and we handle about 2,000 to 3,000 specimens per day. And most testing is completed in 2 to 3 business days after specimen receipt. Next slide. As I said, there's one central laboratory that does all of the testing for the various disorders, and the plates are distributed to 5 areas for further testing. Next slide. And clinical care coordination, once there's an out-of-range screen that has been identified by the laboratory, clinical care coordination is notified and then reaches out to contact the healthcare providers, families, and make certain that that baby gets whatever confirmatory testing they need or whatever further evaluation. And if it's a critical condition, that is addressed immediately, including referral to emergency rooms and any other care that might be indicated at that point in time. Next slide. So for 2019, actually, this has already been updated, and we have identified 902 babies who are affected with one of the newborn screening conditions we screen for. And these are just blood spot based screening. Generally, we run about 900 to 1,000 babies we diagnose every year. That's a huge number of babies when you think about that. And next slide. So the impact of COVID-19 on newborn screening. So in early March, a governor declared a statewide emergency, and our commissioner announced a modified work approach. And there was a functional level of priority. COVID-19 testing and COVID-19 and newborn screening were considered the highest priority, and that both mission essential and business critical. And that helped us transition as we needed to from being on-site to off-site for clinical care coordination, and there were changes made in the laboratory as well. What this slide is showing you is that the birth rate, we knew we were getting fewer samples in, but we also knew that the birth rate had been decreasing. And the CDC releases birth rates, but they lag a little bit. And so there's a research group that matches the CDC numbers pretty closely and releases it quicker. And the estimate as of December 2020 was that there was about a 4.5% decrease in the number of babies that were being born. And so we were felt comfortable that part of the reason we were seeing fewer screens was because of this birth rate decrease. Next slide. So we dropped, as I said, about 4%. It was consistent with the nationwide trend. It was still not clear whether the decline was due to decreased birth rates, although that's what we were thinking, or due to declining submission of newborn screening specimens, which is not the direction we wanted to think about. We had an equivalent decrease in second screens received. And for babies born at the beginning of the pandemic in March of 2020, there was a 50% increase in missed second screens. And that was about 900 babies who we did not see the second screen for. And in our program, some of our conditions aren't really called as being out of range until we have a second screen. And so we instituted some fail-safe measures for those babies that we did not receive a second screen in. Next slide. So in March of 2020, as I said, the agency was directed to telework wherever possible. The laboratory staff adjusted schedules, implemented social distancing, added telework when possible, and stopped work on all special projects. In addition, there was shift scheduling because we wanted as few people on site as possible. And there were physical barriers that were put up, like plexiform distancing in some of the lab stations. And so there were a lot of adjustments being made in the laboratory, but the laboratorians had no choice but to be on site. You have to be on site to run the lab tests. And so testing continued with this. And in addition, the other challenge that was in here was staffing, and that if somebody had been exposed or diagnosed to COVID, that whole area had to go out for quarantine at the beginning of the pandemic. In summer of 2020, the lab staff added additional safety protocols and features, including temperature checks, required masks, added more plexiglass, moved workstations, and readjusted schedules. And then we restarted work on our special projects, which means like bringing up new conditions and some quality improvement activities that were ongoing. Next slide. In addition, for the laboratory, there were shortages of equipment, molecular testing equipment, DNA, RNA extractors. Service and support was very hard to get. The companies that normally handle the support services and handle maintaining the equipment were unable to be on site and unable to help us when we had problems with some of the equipment. And sometimes that meant waiting for a while before we could get, if equipment broke down, it took a while before that could be replaced or fixed. The lab staff got very inventive and managed to do quite a bit on their own, which they usually don't, but we managed to continue screening. Kits for nucleic acid extractions were short reagents for the DNA testing we do. And then even the tips that were used for the testing for the blood-based spots were in very short supply. And the laboratory adapted by finding a new method extraction that went from using 6 tips to 2 tips. And that was just one of the adaptations that was being made during that time period. Next slide. So the clinical care coordination response and mitigation also was very active during this time. We transitioned CCC staff to work remotely with strong DSH support and had minimal in-office rotating staff. And that meant we were not prepared to work from home and work virtually, but that meant that we were all issued new laptops. Those of our staff that did not have agency cell phones were issued cell phones. Our computers originally did not have faxing software that was added on. And by the time we left the offices, we were fully prepared to work from home, and indeed were quite successful at it. One of the other issues that we saw was the medical community was challenged at this time. We continue to provide guidance for the best practices during the pandemic, and we put up a batch of FAQs, which are frequently asked questions. We got lots of calls about what to do if the second screen wasn't possible. And like Carol's program, we had a lot of hospitals where suddenly where the second screen had been done was no longer available. You had to walk through the ER to get to that space, and the ERs were closed. The spaces were not available. Couriers couldn't get to where they needed to be. And so that also became a challenge. And we did, following American Academy of Pediatric guidance, we followed those for clinical care, but we also adapted those for the newborn screening program. And so, we said, get the second screen if you can. If you can't, do it as soon as possible. But we also were problem solving telephone calls one-on-one, in which someone would call or a practice would call and say, the space where we did our screens is no longer available to us. And so we problem solved around the local area to see if there was another practice that could handle those children that needed screening, or changing things so that, well, babies were seen in the morning and other kids were seen later in the day. And so we were offering them clinical guidance in terms of how to change and some possible solutions to their problems. But we still know that there were times when it just was not possible to get that. We also got lots of questions about what to do about early discharges. And like Carol and Iowa, and probably the rest of the country as well, parents did not want to stay in the hospital any longer than they had to. And so our early discharges increased as well. And we knew that it was inaccurate for some of the conditions, and our routine answer is repeat the screen, and that continued to be the answer, but it was repeat the screen when available, because we knew that there would be challenges as well. We provided, as I said, guidance on options to obtain second screens. Second screens were the more challenging part of this, because most babies were born in a birthing center, a hospital, or for us, our midwives had already been engaged in the newborn screening program and did have protocols in place for sending screens. And so it was the second screen when the baby was out at home and needed to be seen by their pediatrician, their family practice doc, or their other healthcare provider to obtain the screen. And that was very challenging towards the beginning of the pandemic. And we again said, get it if you can, and if you can't, get it as soon as you can. That was essentially the guidance that was out there. But at the same time, we were problem solving in microgeographic areas about where it might be available, where it might be open. And we understood that there was also a lot of parent hesitancy at this time, because nobody wanted to bring their healthy newborn out into possibly risking exposure. And so we also provided guidance to families about newborn screening resources, about where they could get the screen, what results would mean. And also our clinical care coordination staff was linking them to healthcare providers to help obtain both newborn screens as well as the follow-up, and the critical follow-ups that were needed were occurring, as well as some of the less critical follow-ups that were happening during this time. Next slide. So we were kind of going along, and we thought we had, we had challenges, but we thought we were doing well. And all the babies were getting screened, we were getting results, they were getting clinical care. And then Winter Storm Uri hit in February of 2021. And this is titled Disaster Upon Disaster. So this was a winter storm that started with an ice storm, and then went on to a snowstorm, and then went on to power failures, and then went on to lack of water and supplies during that whole week. It was essentially a whole week's time that we went through this. And in addition to dealing with that, our program also was facing another disaster, in that we had lost one of our lead nurses, had passed away suddenly and unexpectedly. And so we had to quickly scramble and cover the activities that she would done. And it's not that we didn't have the redundancy and the ability to do it, but it was a disaster for us to have to recover from in the midst of everything else that was going on. We had specimen pickup, transport, and delivery services were completely disrupted from 2/15 to 2/17. Partial disruptions began with the ice storm on 2/12, and limited services resumed on 2/18. Specimens that were shipped by USPS were unable to be delivered until Monday, the 22nd. The laboratory was completely unable to operate for 3 days, from the 15th to the 18th, and full operations resumed the next Saturday. Due to the excessive backlog of specimens and the risk of further laboratory closures due to regional water pressure issues, We redirected about 1,200 specimens to a reference lab. And then to expedite completions of backlogs and specimens that had been delayed in transit, there were specimens that were sitting in our courier hubs. There were some in the hospitals. There were some that were in the lab that initially had been unable to be tested. The lab operated at surge capacity through February 26, which included testing on Sunday, 2/21. And the clinical care coordination operated on those same hours as well through surge recovery. The backlogs of the first screen specimens we caught up on by 2/21, and the second screens were completely caught up by 2/24. And that's a pretty quick recovery given the volume and the disbursement of all of those samples. We did receive, because of these delays at that time, there were over 1,300 specimens that were considered too old to test by laboratory regulations based on regulatory requirements. However, we did make the decision to test them. And these were reported as specimen too old upon receipt. And usually the facility is asked just to repeat that specimen. And that was the reporting that went out to repeat specimen. But at the same time, we were concerned about possible further delays for the baby. And so what we did was they were tested. If there was an out of range screen where the baby needed more testing or needed a clinical evaluation, we called clinical care coordination, called the healthcare providers and told them about the out of range test. And this did create a little bit of confusion because the healthcare providers are used to looking at a written report or on the screen. And the reports were saying too old to test, but yet we were calling them and saying this is out of range and here's our guidance on what needs to happen. And so that took a lot of time trying to educate our healthcare providers about what we were doing and why we were doing it and what the results might be. We followed up on any results from the unsatisfactory specimens that were tested and that required immediate notification. Next slide. So even the specimens that had been sent out by the laboratory for testing, follow-up was done by the Texas Clinical Care Coordination, and we had coordinated that the results were going to be coming back to us through folks from that reference lab, but all the Texas Clinical Care Coordination were contacting their healthcare providers and the families as needed. This was a manual process. We didn't have, none of these specimens were in our electronic databases or LIMS, and so it was very time consuming and manual. During this time also, the team supported each other with many members of the team without power, heat, and water during this period. And so sometimes it was roving. At the beginning, there were power outages that were spotty in one area of our region and not the other, and so things were being shifted around. All of this was being coordinated with DSHS cell phones and landlines, and that was a lifeline for the newborn screening program. There was lots of coordination, lots of calls planning on how to do this and really adapted as this was happening. We provided education on the new differences of the newborn screening reporting because suddenly providers were seeing a report they weren't used to seeing and didn't know exactly what it meant. And there were some surprises for us as well on the reporting that we had to sort through and provide guidance for the baby. Linkage to care, though, continued through all of this. We provided guidance for follow-up measures on both the outer range test, the internal and external screening, and provided guidance to medical providers that they really needed to check to see that that newborn screening was done and that they had the results. And even if it wasn't obtained in the usual time frame, it did need to be obtained. Next slide. So what lessons did we learn? And we're still a work in progress. You know, we're still learning from our experience. One was that the dedication and resourcefulness of our staff was amazing and was critical to the response. We had continuity of operations planning and it served us well, but we can strengthen this. There were scenarios not planned for that became a reality. just like for COVID, our initial planning had been to rely on other states, but every state in the country was impacted the same as we were. For the Texas storms, we did not expect the whole state to be impacted, and our initial coup had included using other parts of the states for backup, which was not a possibility once the whole state went down, except for a small part of El Paso. Collaborative laboratory and follow-up services are essential. Communications, and this I can't emphasize enough, with providers and parents are critical in maintaining the benefits of newborn screenings for families. We also learned that our recovery period was as stressful as the event itself, and that families impacted by newborn screening during disasters may need additional support. And I think that was the last slide. So I want to thank you for listening to us. I'm happy to answer any questions, and this is my contact information. And thank you all for joining us.
Thank you so much, Dr. Friedenberg, and again to Carol. I know we are coming to the end of our time together, but we do want to just open it up. There's been a number of great questions posed in the chat box, some of which I think, Dr. Friedenberg, you were able to address in regards to next steps for that second screen. But I think there are some other great questions. So I will pose them. If anybody would like to jump in and ask as well, feel free to unmute yourself. You are welcome to ask. And I will also just add that before you drop off, we're going to ask for one more bit of feedback and one last poll. So Brian, if you want to go ahead and bring that up while we're asking questions, we'd just like to capture some feedback on how you feel about this webinar. So while you're doing that, Carol, I think a question for you from the chat would be specifically, have you compared time to diagnosis or time to treatment before and after the pandemic? So I think
yes, that's
great question.
Yes, that is a great question. So the LIMS system that we currently use is not robust to give us that kind of granular data. However, I have asked if we can get some of that information, but I don't have it at my fingertips. So right now it's just anecdotal stories, unfortunately.
Thanks for that. Another question, I think, to either of you that was posed in the chat box. Do you have any knowledge or know how often newborn screening results might be available to families through the EMR? Sort of thinking of those different strategies in time.
Yes, I would like to address that, and I have been meaning, it's on my to-do list to actually send something out to the listserv. So some of you may be familiar with the Cures Act. And so what, in a nutshell, what that means is that the minute, what we're seeing in Iowa, the minute that the laboratorian pushes submit, it goes out through electronic messaging to those hospitals that are hooked up with us in electronic messaging. And so, true story, sometimes families are seeing the results before follow-up even knows about an abnormal result, or a provider knows about the result before follow-up is aware of it, because we have just the lag of the phone call sometimes. This has caused a couple of problems already. In that we had a nurse call a clinic, call parents before we'd even called the clinic. So something to be aware of, and I will still try to post something in more depth on the APHL listserv. But yes, Joan and everybody, sometimes now patients and parents and providers are seeing results before newborn screening programs have a chance to actually contact the parent or the PCP. So interesting times we live in.
Yeah, so we are a little less electronic than the Iowa system is. We do have hospitals and large systems on HL7, which do get their results that way, and then that would go directly into the EHR. And so it is possible for a parent, with the new act, for a parent to see that result before the before the physician sees that. However, our clinical care coordination staff is calling, immediately when we get the out of range result. And we do call the healthcare provider, but if for some reason we cannot find the healthcare provider, we will call the family directly. And in addition, the family for out of range tests, the family will get a letter from us, but that is much later on. That's not in the, it's going to take the mail and that's going to take a little time to get to them. So we haven't faced that situation yet where a parent has been made aware of an out of range result before their healthcare provider has, but we expect it's within the realm of possibility with those institutions that we share electronic results, or what we call HL7 results, with them. And just to make you aware that with that act, any patient can look at their records, anything in their records. And I know that has caused the medical community some angst, because sometimes there's some testing that you want your medical provider to explain to you that has life-changing impacts, and reading it on a screen may not be the best way to communicate that information and to support that family, because you can't really ask questions about it, and you can't give prognostic information. You really can't support the family just reading a report. So, and all of our reports do have telephone numbers to call back in with the nurse or our PHPSs that are responsible for that case. So we do have contacts available for all the parents on those reports as well. Not the report itself, on the abnormal report that when CCC calls out. The vast majority of screens are going to be electronically generated, and there's going to be nothing out of range, and we will not hear from the parents on that situation.
So I appreciate that there are a number of questions that we didn't get to, and we could probably have an additional 30 or 45-minute forum to just discuss so many of the challenges and the strategies that you both implemented within your programs. I can't thank you enough for what you shared with us today. And again, I think it's such an interesting perspective to not only consider the lessons learned supporting families through COVID and a pandemic, but on top of that, to also have to navigate what you do when things just truly completely shut down at the same time. And so I think there's a lot to really think about and process. You both touched on the importance of adaptability and flexibility, the importance of communication. And while all of those things were important pre-COVID and pre these other emergencies, they're even more important and so critical to emphasize when thinking about supporting families through these experiences. So I think you both highlighted exceptionally well how you've had to be innovative and flexible and adapt within your programs to continue and maintain successful programs, and to just emphasize that babies were screened despite the challenges that your programs have had to face over the last year. So I want to thank you both. I want to thank everybody for attending. If there is a question that we did not address, feel free to drop it in the chat box before you log off. And we'd be happy to coordinate some responses with our wonderful panelists and get back to you with those. And the last thing I'll mention is that we also wanted to just let you all know, in case you were not already aware, that specifically through the Newborn Screening Family Education Program, we do have an online module dedicated to newborn screening and COVID. So for those of you who are attending on behalf of advocacy groups and state programs, please know that that's an additional resource available to you all to share with families at this time. And we also have a wealth of additional information and education around newborn screening as well. So thank you all for sticking with us for a few extra minutes. Thank you again to Carol and Dr. Friedenberg for your wealth of knowledge and experience that you've shared. We look forward to continuing this series with our last and final session. More information will be coming in May, but we're looking forward to bringing a panel of families together to share their experiences with newborn screening. And so please be on the lookout for that. And thank you again for joining us this afternoon. We really appreciate it.
Thank you.
Thank you.